Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our experts. This evening, Jefferson Health otolaryngologist will answer your question about sleep disorders, treatment options, excessive sleepiness, and much more. Well, thank you so much for submitting your questions in advance. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. And if you have any questions throughout our discussion tonight, for those joining us on your computer or tablet at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, without further ado, I want to go ahead and introduce our experts for the evening, starting with Dr. Maurits Boone with otolaryngology and Dr. Colin Huntley with otolaryngology. Welcome both. I'll go ahead and just give each of you a minute or two to just say hello, and you can provide a little bit of background information about yourself. So, Dr. Boone, we'll start with you. How are you doing this evening?
I'm doing great, thank you. Welcome, everybody. Nice to be here. Happy to answer questions. And my name is Maurits Boone. I am an ear, nose, and throat or otolaryngologist by training. I'm also boarded in sleep medicine. And I've spent pretty much the better part of the last my career primarily focused on treating obstructive sleep apnea and sleep disorders, both medically and surgically.
Okay, well, welcome. Thrilled to have you. Okay, and Dr. Huntley, how are you doing this evening?
Hi, Sarah. Thanks for having us. Thanks, everyone who's joined this evening. But I'm well. So I'm Colin Huntley. I'm also a otolaryngologist or ear, nose, and throat doctor. Like Dr. Boone, I have a secondary board certification in sleep medicine, and I did training after residency, fellowship training after residency in sleep medicine and sleep apnea surgery. So the primary focus of my clinical practice is treating sleep apnea through a number of different modalities, and then also associated sleep disorders. And then we have a number of ongoing uh, research studies and participate in a number of clinical trials too surrounding the same topic.
All right. Well, great. We're thrilled to have both of you, and I know that we're going to have a wonderful and engaging discussion this evening. So, without further ado, let's go ahead and dive into the questions. So, the first submitted question we have here is for Dr. Boone. Can you discuss the differences between sleep apnea, central sleep apnea, and obstructive sleep apnea? And is one worse than the other?
So sure, first and foremost, obstructive sleep apnea is your sort of common variety bread and butter, and really the most common sleep disorder. And that is specifically a situation when during sleep you actually have episodes where the throat and parts of the upper airway actually collapse and gets in the way of the airflow. Um, that's again the more common variant. The less common variant is called central sleep apnea, and that essentially is when the brain is not telling the body to breathe. From the standpoint of what's more serious, they're very different animals, and I'm not sure you can say one's worse than the other. But obstructive sleep apnea is far and away the more common one, and the thing that we have to treat the most commonly. Very briefly, so I don't take up too much time with this. This is the thing that people would associate with snoring and the gasping and the pausing and the choking. And generally, people experience a lot of daytime sleepiness, just not feeling like they get refreshing, restful sleep at night. And we can obviously delve into all the treatments and the diagnoses. I'm sure we'll do that in the context of this, but that's just sort of a brief overview.
Okay, great. And as a follow-up question to that, should a person be reassessed every so often for the severity of each one?
It depends a lot in terms of a couple of different things. Primarily, number one, if symptoms get worse, but probably the more significant component of that is that if things otherwise change in your health history, especially weight. So weight is a really big factor in obstructive sleep apnea. And if weight increases or if it decreases for that matter, you may want to be reassessed to see if things changed, got better, or unfortunately also, of course, got worse.
All right. And I know you just talked through the symptoms of sleep apnea, but I guess for the audience, why should we care about these symptoms?
Yeah, that's a great question. It is really important because it has so much of an impact, obviously, on your quality of life. So it affects, of course, your daytime sleepiness, your ability to function. It puts you at risk for motor vehicle accidents. It puts you at risk for actually being smothered by your bed partner because they don't like the noise that's associated with the snoring, and so they may put a pillow over your head or push you out of the bed. But really, fundamentally, the reason it's important is because it's linked to so many health disorders and really more that we discover each day. So, two times risk of stroke, heart attacks, heart failure, atrial fibrillation, which we see all over commercials these days. Those are some of just a few of the things, but diabetes. It has a significant relationship making obesity worse. So obesity makes it worse, but it also makes obesity worse. So it's really linked to a myriad of health conditions. And so it really is important to recognize because it has direct impact on shortening your life, unfortunately.
Okay. All right. Well, thank you so much. All right, Dr. Huntley, we will turn to you now. How does one get tested or screened to see if they have any of these sleep apneas? And are there at-home and in-office sleep tests?
So there's a number of different screening tools, which are questionnaires or things that can be found online, or that sometimes will be done in a primary care office, or if someone is having surgery and the anesthesia team is evaluating them. That just gives you a sense of risk or what we think of as pre-test probability. That just means what's the likelihood of having sleep apnea if you have a sleep test. In terms of official testing or more sensitive testing, there's both in-lab sleep testing and home sleep apnea testing. In-lab sleep testing is called polysomnography. It's where you come into the sleep lab, you sleep overnight, a number of different wires are hooked up to assess your brain waves and what stage of sleep you're in, to assess your respiratory effort, to assess airflow, and that's used to diagnose sleep apnea, but then a number of other sleep disorders that certainly can affect sleep quality and daytime symptoms. Home sleep apnea testing has become much more commonplace, much more popular, and has improved over the years too. This is certainly a more convenient option for many patients. And it's a kit that is either picked up or by the patient or is mailed to the patient's house. It's a pretty simple to use kit where there's a small airflow sensor that looks like an oxygen cannula you'd see in the hospital that goes just on the inside of the nose, a pulse oximeter that sits on the finger, and then a belt that goes around the chest. It's worn for 1 or 2 nights and then mailed back to assess that data. The limitation of the home sleep apnea test is it's really just looking for sleep apnea, and it can't assess a lot of the other sleep disorders that you can see with an in-lab study.
Can
Okay.
I ask a question for you, Colin? Because it's really important. How about all of the home stuff that's out there, like watches and all those things?
Mhm.
How good are those at telling these things?
Not. So it's a great question. And there was a whole body of evidence that came out maybe 15 years ago when the Apple Watch and Fitbit and all of these things started to come to fruition. And everyone's looking at their sleep quality and their sleep stages and their snoring data. And the data is interesting to look at. And I mean, to be perfectly honest, I look at mine when I wear my Apple Watch at night, and I've used it to take screenshots of it and use in presentations. But when you look at the research that's been done with the current technology that's available, the watches are reasonably good at assessing sleep and not sleep or wake. But when it and the snoring data is reasonable, but it's not very good at assessing different sleep stages, and it certainly is not very good at assessing sleep disorders.
Okay. Interesting. Thanks for the question. And I know you mentioned, the benefits of the at-home sleep tests, but would you recommend doing an in-lab sleep study first before doing the at-home? Any thoughts there?
Generally, we start with a home sleep study. One of the reasons is insurance coverage. Perfectly honest, many insurance companies, unless there's severe cardiovascular comorbidities or you're worried about a sleep disorder that's not sleep apnea, we have a hard time getting an in-lab sleep study covered first. But it's usually very, very easy to get a home sleep apnea test covered. So that tends to be our first starting point.
Okay. Thank you. All right, Dr. Boone, back to you. Are these conditions permanent, and are there cures or anything to help lessen the severity? Oh, and I think you might be on mute.
You think by now, after all the years of Zoom, I'd figure that out. The short answer is, as a general statement, we expect it to be a lifelong disorder, but it can be modified. Single biggest element in terms of modification is really body weight, body mass index, and losing weight is what is really the primary X factor in this. There are some limited things you can do. So changing your body position helps. Specifically, usually the back is the worst place to be, but even a little bit of head elevation may help a little bit, but those then are generally don't help a lot. And the practical side of things is that while body position may affect people significantly, people don't generally like to be confined to one position during sleep. So trying to tell somebody you need to stay off your back doesn't usually work. We usually spend about 30% of the time on our back. And so it's something that seems to be easy in concept, but unfortunately in practical terms is pretty difficult for people to maintain. So
All right. Well, thank you. All right, Dr. Huntley, back to you. Is use of a CPAP machine, if that's needed, is that permanent?
Uh, typically, yes, we tend to think of it as a treatment for sleep apnea, not necessarily a cure. And a lot of the other interventions that are out there could be considered treatments in the sense that you're using it every night, just like you're taking your blood pressure medication every day, or someone with diabetes is taking their insulin every day. Um, as Dr. Boone said, we think of this as a lifelong disorder unless there's some intervention that's done or significant lifestyle change. But yes, typically CPAP is used on a nightly basis for life.
Okay. And can you discuss the differences between a nasal sleep apnea mask and then a full mask?
Um, I think you just did, Sarah.
Oh, all
No,
right.
it's so a in the terminology kind of describes it. One is so there's a nasal mask which just goes over the nose, and it's kind of a triangle type disorder. Sorry, my 3-year-old came in. Uh, the sits over the nose. The a full face mask sits over the entirety of the face, so the nose and the mouth. Um, there's also a nasal pillow mask, which just sits underneath the nostrils and seals to the nostrils. The conventional wisdom is that a nasal CPAP or a nasal pillow CPAP is a lot more comfortable. The research data shows us that the pressure delivered or the pressure required from a CPAP device to keep the airway open and to treat the sleep apnea is lower through a nasal mask than a full face mask. So it's not only tends to be more comfortable, but it doesn't take quite as much pressure to keep the airway open and keep it from collapsing.
And Colin, in the chat, somebody had posed the question, has sleep apnea equipment or sleep equipment become any more comfortable to use in recent years?
I think the short answer is yes. The machines have gotten smaller, the machines have gotten quieter. And then been a lot of change in the mask designs and the headgear design and where the tubing or the hose is coming off. So many of the nasal CPAPs or nasal pillow CPAP masks will have the hose coming off the top of the head as opposed to right off the front of the face, which allows people more mobility in bed. They can roll over without getting tangled as much. And then in terms of some of the features that have been developed, it certainly makes it more comfortable. So humidification, heat can be applied to make it more comfortable. And the last thing is ways that we can optimize CPAP tolerance. So someone who has bad allergies and they just can't breathe it all through their nose in the springtime, managing those allergies aggressively can make CPAP a lot more tolerable in the same sense that someone who grew up with boxing as a hobby and had a broken nose and can't breathe out of the left side of their nose, regardless of the season, nasal surgery to primarily improve their nasal breathing has been shown to really significantly improve CPAP tolerance by lowering the pressure and optimizing the type of mask they can use.
Okay, very interesting. Thank you. And yeah, a friendly reminder, feel free to put any questions in the chat. We will get to those live questions in just a bit, but feel free to keep adding them as they pop up. All right, Dr. Boone, we will turn back to you. How can one get approved for upper airway stimulation therapy, and what is that, and how does it work?
The short end of things is so upper airway stimulation is an alternative treatment for sleep apnea. One of the requirements is that people have to have tried CPAP and failed. One of the things that's important to know is that what actually constitutes a failure of CPAP has, for better or worse, not really been well defined by any governing body, by any insurance company or otherwise. So CPAP failure for some people means that they've tried it for 10 years and said, I've finally given up hope. And for other people, it means they go get a CPAP, put it on their face, and rip it off because they're claustrophobic, and that's the end of their trial. What I always tell people, first and foremost, is that if you're going to try CPAP, give it a real try, because for some people, it can be life-changing. But getting back to your original question, upper airway stimulation is a treatment that is a surgically implanted device, and what it's designed to do is stimulate the nerve to the tongue. And in that process, what the nerve to the tongue does is it actually stimulates the tongue to stick out of the mouth, which opens up the airway. So it's implanted through a surgical procedure, generally been very safe and well-tolerated procedure. Important considerations about upper airway stimulation. Number one, there are criteria for consideration. And the other important thing is that it's not for everybody. So if I take a step back for just 1 second, and forgive me for being too detailed here, but again, getting back to this fundamental consideration, when you have sleep apnea, something in your throat is collapsing, obstructive sleep apnea specifically, something in your throat is collapsing. The problem is, from the standpoint of when we determine an alternative solution for patients, is that what, where, and how things collapse is unique for every given individual. So certain patterns of airway collapse, certain things that collapse are very responsive to upper airway stimulation, and others are not. And so when we consider upper airway stimulation, number one, there are criteria based on severity of sleep apnea. So it has to be moderate to severe. Number two, they have to have tried and failed CPAP. Number three, they have to be within a certain age range. Generally, it's between 18 and above. And then they have to have a component of, they should have no more than 25% of their sleep apnea be what's called a central sleep apnea, which we talked about before. The last important consideration is that we do an evaluation in the operating room called a drug-induced sleep endoscopy. And what that is an attempt to actually understand mechanically what is contributing to that airway collapse, to what is actually specifically causing that collapse in any given individual, so that we can identify whether there are patterns of airway collapse that are going to be ideal or patterns of collapse that may be less favorable that would suggest that they're not a good candidate.
Okay. All right. Thank you. All right. Moving along, Dr. Huntley, we will turn back to you. So we are seeing everything right now from mouth guards and most recently mouth taping. How effective are these methods, and what are the pros and cons of these?
So there's not great data about mouth taping being a primary treatment for clinically significant sleep apnea, meaning moderate and severe sleep apnea. It tends to be more of a snoring option or snoring treatment for a lot of people who snore and primarily breathe through their mouth, with the goal of trying to close the mouth and optimize or promote nasal breathing. Mouth guards there's a lot of data and a lot of history using mouth guards, or what is kind of technically defined as a mandibular advancement device for treating sleep apnea. And these are devices that go into the upper and lower teeth, and they protrude or support the lower jaw to try and pull the tongue forward and help to open the airway. It tends to be best utilized in someone with mild or moderate sleep apnea. Patients with severe sleep apnea certainly can benefit, but it doesn't tend to be as effective. It's another alternative treatment in patients who have tried and not done well with CPAP. It tends to be a bit better tolerated than CPAP. And when you look at some of the outcome data in terms of improvements in cardiovascular variables like blood pressure, for patients with mild and moderate sleep apnea, it's as effective as CPAP in reducing or improving the blood pressure long term. I guess the other factor to consider is there's both over-the-counter mouth guards and then more custom-fit mouth guards that the dentists will make. The official recommendation is for someone with clinically significant sleep apnea to get a more custom-fit mouth guard through a sleep dentist, as they tend to be much better fitting and sturdier than some of the over-the-counter varieties that are the boil and bite plastic that you can put in warm water and then mold to your teeth.
All right, super helpful. Thank you. Okay, I want to talk a little bit about snoring now. I know that's a huge topic for many people. Dr. Boone, are there remedies to help reduce snoring or even end it completely?
So the first question to answer in this is that when you have somebody who's snoring, is to answer, is this snoring, simple snoring, or is this snoring plus sleep apnea? Because they can go hand in hand, of course, and it certainly can be a sign of obstructive sleep apnea. So my first commentary would be to make is that if there is significant snoring, you should probably be screened for sleep apnea just to make sure. Second commentary to make is there are many treatments for snoring, but just like sleep apnea, there are some different mechanisms by which it happens. So fundamentally, again, it's something that's in the airways collapsing, but it's sort of, you could consider it like a spectrum. That is, sleep apnea is more severe obstruction, snoring is less severe obstruction, and that's less severe obstruction causes turbulent airflow, which then causes the tissue to vibrate, which then causes the noise associated with snoring. But where exactly that's taking place in the airway can be different from person to person. So again, it needs a tailored approach. Um, so I would say first and foremost that we should make sure you're screened for obstructive sleep apnea just to make sure there aren't health consequences. And then it's really, again, about taking a good history and physical examination and trying to identify what's mechanically causing it. One of the other problems associated with snoring is that it's not considered a medical problem by insurance companies, so they don't generally cover much in the way of snoring treatments, unfortunately. But there are surgical things that can be done. Number one. Number two, the mouth guards or the oral appliances or the mandibular advancement devices that Dr. Huntley just talked about are one of the solutions that can certainly be considered. Again, if it's purely for snoring, they're generally not covered by insurance companies, but there are surgical things that can be done. The last commentary to make is that when we treat snoring, generally our goal is to get people to reduce their snoring to a point where it's not bothering their sleep and where it's not bothering their bed partner's sleep. But we're not usually optimistic that it's going to be a zero on the snoring scale, unfortunately.
All right, thank you. Okay, Dr. Huntley, we will turn to you. A few more questions here before we go to the live questions from the audience. But Dr. Huntley, do you mind talking about what are some other common sleep disorders besides sleep apnea?
I mean, the most common sleep disorder is insomnia, which is broken down into sleep onset or sleep maintenance. So, sleep onset insomnia is difficulty falling asleep. Sleep maintenance insomnia is frequent awakenings and difficulty falling back to sleep. And it's something that at one point or another, pretty much everyone experiences, with up to about 20% of the population having chronic insomnia on a more regular basis. That's the most common disorder that you see, and a lot of times you'll see it in combination with sleep apnea, with one worsening the other, so to speak, but both kind of independent disorders. And then I think there's 87 sleep disorders within the diagnostic manual for sleep medicine. So they're broken down into disorders of sleep disorder breathing, which is sleep apnea, insomnia disorders of hypersomnia, meaning you're just excessively sleepy during the day, and that's where narcolepsy would fall. Disorders of sleep behaviors, so things like REM behavior disorder, where you act out your dreams, but that also includes sleepwalking and sleep talking. So there's a number of things that are much less common, but certainly we see, and they can occur in combination. So just having one doesn't mean you don't have another one.
Okay. And overall, I mean, this is a pretty broad question, but is there relief for these different sleep disorders that you're describing?
hmm So, just insomnia, for example. So, the two typical treatment modalities, first one is optimize your sleep hygiene. So, limit caffeine in the afternoon, limit the amount of electronics that you're using before going to bed, have a kind of sleep routine, so to speak. In terms of actual treatment, there's cognitive behavioral therapy for insomnia, which is a specific program that's done in order to optimize your sleep behavior, but also optimize kind of your subconscious approach to sleep. And then there's a number of medications that can be used and have been designed to treat both sleep onset and sleep maintenance insomnia. Um, Cognitive behavioral therapy and medications are basically equally effective. They're just different roads to get to a similar destination. And then the other sleep disorders, yes, there's certainly treatment options for everything that's been described. It's usually those are medication based. They're not surgical treatments for the other sleep disorders that aren't sleep disorder breathing.
Okay. All right. Thank you. All right, Dr. Boone, we will turn back to you. Is there any remedy for night shift sleep disorder? And are there non-addictive sleep medications that you could discuss?
The first commentary is night shift disorder. The best treatment for it is get off night shift. Sadly, unfortunately, that's the case. The what we know about night shift disorder is that no matter how long you do it, no matter how much time you spend trying to get adjusted to working at night and sleeping during the day, the body has an innate desire to want to sleep during darkness and want to actually be up during the light. And so the brain really never fully adapts, and we recognize that shift work disorder actually has pretty significant impact on your health. So in general, if possible, but many jobs just simply don't permit the opportunity to work and work during the day and be asleep at night. There are certainly non-addictive sleep medications, and I think it's important when you talk about, medications for sleep that there's a difference between addiction and dependence and need. Addiction to me, it really suggests that you sort of have something that you benefit from this in a way, in a sense that you get I don't know, you want to call it euphoria or something else that actually drives you to want to use it. Dependence instead is something where you may need the medication for function and you may actually require it, but I don't consider they're really not synonymous. And there are many people who, unfortunately, because of their insomnia, do require medications long term. In an ideal world, of course, that wouldn't be necessary, and we usually try to offer cognitive behavioral therapy for sleep, as Dr. Huntley indicated, as an adjunct to that. But sometimes medications are also an important component of that whole process. So, but I don't generally consider them addictive as much as that people sometimes, they have a need for them in order to function and to sleep.
Okay.
I use the term reliance a lot as opposed to true addiction where you have a withdrawal type thing.
Yeah, definitely a difference. So that's helpful distinction. Thank you. Okay, Dr. Huntley, last question here before we turn to live questions from the audience. What are the newest treatments in sleep disorders? Anything out there that could be cool and innovative for people to hear that are listening tonight?
Which of the 87 should we talk about? So I mean the hot button one is, or the most common ones are insomnia and then sleep disorder breathing or sleep apnea. So insomnia, there's new medications that are coming out yearly. So there's kind of an algorithm or guidelines that have been published by the American Academy of Sleep Medicine in a ways to address this. And cognitive behavioral therapy is something that is right at the forefront there, and it's something that we always talk to patients about. Some patients are very gung-ho and interested in that road. But then there's the medication algorithm that is changing and updating as newer medications are being developed. And these are going after multiple different pathways. So histamine pathways within the brain, orexin, which is a protein that's actually related to narcolepsy or a causative problem in narcolepsy, but trying to take advantage of that neural pathway to help with sleep. These are just some of the newer medications that are out there. In the sleep apnea field, so break that down into both medical and surgical treatments of that. In the medical realm, that's CPAP primarily, and as we referenced, CPAP is improving year over year or 5 years over 5 years, at whatever time point you want to look at. And that means it's getting smaller, it is becoming more comfortable. There's new features that are available. And we're also getting better at customizing it or trying to optimize it for patients as well. And that includes screening and assessing for some of these alternative sleep disorders. The one-liner I use all the time is if you have insomnia and sleep apnea and you can't fall asleep at night, well, you're certainly not going to fall asleep by simply putting a mask on your face. So identifying and treating both of those problems can be very helpful in optimizing both disorders. Um, the newest technologies that are developing are in the treatment of obstructive sleep apnea. So Inspire is a neurostimulation device, as Mal referenced, is kind of a pacemaker type device for the nerves of the tongue. That's been out for a decade. There's hundreds of papers that have shown efficacy of that and predictors of success for that. And there's newer technologies that are coming to light and going through the FDA approval process right now, where there's two companies who have finished their kind of pivotal trials within the US. And there's a number of startup companies that are looking at newer approaches or techniques to stimulate this specific nerve, stimulate other areas in the upper airway, and optimize airway opening. And I guess the converse of that is limiting airway collapse that's leading to sleep apnea. And then there's a number of kind of classic surgical approaches as well that are constantly being redefined or refined, I guess, to optimize outcomes and limit complication rates and limit kind of long-term issues that have classically gone along with them.
Okay. All right. Really fascinating to hear and promising to hear too for a lot of folks listening tonight. So thank you. All right. Well, with that, let's go ahead and dive into the live questions. Thank you all for submitting. I see the chat blowing up, so that is great. So I will go ahead and just read them out, and whoever wants to respond, feel free. This is, as we've been doing, definitely a conversation. So the first one here, can you speak to the efficacy of melatonin or ZzzQuil and any other sleep medications? Are any of these better or worse than the other? So I know we've kind of touched on this, but any additional thoughts there?
If you want, Colin, I can take it and you can jump in and fill in the gaps.
Sure.
The first important thing to understand, melatonin is generally a very safe medication, not generally terribly effective, but one of the important considerations is that it's not FDA regulated.
Mhm.
What that means is there's a lot of variability between products, and so that unless you get it from a really reputable distributor, you really can have variations, just even pill to pill in the bottle. And so very safe, but generally not terribly effective. For the majority of the over-the-counter sleep medications like ZzzQuil, et cetera, they primarily rely on Benadryl, and which is not a terribly effective long-term sleep medication. And as many people are aware, it often leaves you with a pretty good hangover in the morning, just feeling like that fuzzy, feeling in the head. So it generally will help you to get to sleep, but we don't generally consider it a really effective sleep aid. We generally tend to, unfortunately, rely more on the prescription forms of sleep medications if you're going to go that route. There aren't too many over-the-counter preparations, which to date have really shown, have had good studies backing their use.
All right, thank you. All right, next question here. What is the difference between obstructive sleep apnea and narcolepsy?
So two different classes of sleep disorders. So obstructive sleep apnea falls under what's called sleep disordered breathing, which means recurrent collapse of the upper airway soft tissues that leads to disruption in airflow and is associated with snoring and sleep disruption and daytime sleepiness, and then a number of downstream cardiovascular risks that we touched on earlier. Narcolepsy falls under the disorders of hypersomnia. So the most common symptom of narcolepsy is poor sleep quality at night, but then also excessive daytime sleepiness. And excessive daytime sleepiness is that common symptom that you see with sleep apnea as well. But narcolepsy is a central nervous system disorder, or it's centered in the brain, where you're not able to consolidate sleep at nighttime. So you have very poor sleep quality at nighttime, leading to just exhaustion during the day and quick onset of sleep, quick onset of REM sleep because of how kind of poorly consolidated it is at night. We touched on some of the treatments for obstructive sleep apnea. Narcolepsy is primarily treated with it's diagnosed, I guess I should say, with a sleep study that's done at nighttime and then followed up with a daytime study. So you're at the sleep lab for almost 24 hours to look to see how you sleep at night, but then also how quickly you fall asleep taking naps during the day. And it's primarily treated with different medications, either during the day or at night, depending on the specific prescription medication, that pathway that you're following.
All right, great. Thank you. Okay, next question here. Is sleep apnea potentially fatal? Could you die in your sleep?
Short answer is I don't think people should get too worked up that it's going to be, that you're going to suddenly die in your sleep. There are cases and things where we see this. What I would say is you don't have to fear that it's going to be your last night of sleep tonight if you suffer from sleep apnea. It's really more the long-term issues that we face. And so it's the repeated episodes night in and night out that just start to exact their toll. But I think it's important that people don't get too sort of fixated that you can die in your sleep because that's really very, very rare.
Okay.
Well, it's also not sleep apnea that causes the death or mortality. It's the heart attack, the stroke, or the things that the sleep apnea increases the risk for. So the idea that you stop breathing and you just don't start again is not really a thing. That's not what happens. But the stress that the sleep apnea and those repetitive events have on the heart, or the risk that it has for a irregular heartbeat or cardiac arrhythmia, or the risk for stroke, that certainly is real, and that tends to be what people suffer from.
Yeah, and that maybe actually leads into the next question,
Yep,
just in the
exactly.
chat, which is, can
Yep.
you further describe the causation factors between sleep apnea and heart
Ah,
disease? And so, yes, we certainly can. There are two primary factors which really actually lend themselves to causing heart disease and heart issues. The first is the repetitive episodes where the airway collapses, where you just simply are having reduced oxygen. And that reduced oxygen then creates cardiovascular stress that repeatedly causes issues. So that actually repeatedly over time starts to actually exact its toll on the cardiovascular system. The other major mechanism is what we call arousals. And so what arousals mean is that there's this essentially fight or flight response that occurs every time you actually have these episodes where you stop breathing. The brain recognizes you're not breathing and actually will stimulate you to either wake up to a lighter stage of sleep, which we call an arousal. And that actually then again stimulates a fight or flight response, which over time can then actually just cause what we call sympathetic tone. And that is basically, again, the fight or flight response, which then actually starts to actually increase your blood pressure. It actually starts to then cause issues like just causing your heart to be sensitive so that it then now is prone to arrhythmias like atrial fibrillation, and other arrhythmias that we see.
All right. Thank you. And really interesting to hear that connection. I guess the next question here about impact. How does your diet impact sleep? And also the four different seasons. I know allergies was mentioned a bit earlier.
Um, they kind of do, but not really, I guess is the vague way of saying it. So, seasons, I think two things come to mind. One is during the winter time when it's dark out, so much more seasonal affective disorder comes into play, which is almost a kind of depression type picture for a lot of people that occurs when just by not having as much sunlight. And that certainly can affect sleep quality and the ability to fall asleep too. Um, as you mentioned, allergies for sure, chronic nasal congestion or difficulty breathing through your nose absolutely affects sleep quality. And we have good data showing that in people who are able to breathe through their nose effectively and aren't mouth breathers, the quality of sleep is much better. And then secondarily, also they're not waking up with dry mouth and they may snore a little bit less. There's an interesting book that was written years ago by a guy named James Nestor, who it's called Breathe. So he just kind of accounts his experience from a lay perspective dealing with nasal obstruction. He participated in a study at Stanford where they plugged his nose for 2 weeks and then were assessed a number of variables. And it's an interesting account of what people deal with when they really can't breathe through their nose. So that if it's related to allergic rhinitis, seasonal allergic rhinitis, definitely can affect things. Diet on a day-to-day basis, not so much. I mean, when Dr. Boone goes out and eats chicken wings and beer for Monday Night Football, he's certainly not gonna sleep very well on Monday night just because his reflux is flaring and it's outside of his normal diet. And then long term, diet in terms of weight gain absolutely can affect sleep because of the risk of apnea. And the last thing would be eating later at night can affect insomnia, and ingesting caffeine or alcohol definitely can affect sleep. So caffeine is going to make it difficult to fall asleep. Alcohol will make it easy to fall asleep, but it's really going to disrupt or alter the how consolidated your night of sleep is, or be associated with multiple awakenings. So although you fall asleep easily with alcohol, you're going to wake up a lot more tired because it's a poor quality sleep.
Okay, thank you. All right, next question here. This person is wondering, what has data about upper airway stimulation therapy shown about its effectiveness?
Colin, you want to take it?
Sure. I mean, so it's been out 10 years. So I should couch it with this, because upper airway stimulation is kind of an industry specific term for Inspire. That's what Inspire has kind of coined. Hypoglossal nerve stimulation is more of the umbrella term. So the hypoglossal nerve is the nerve that controls motion of your tongue, and that's what's being stimulated. And the reason I kind of make that distinction is because the vast majority of the published data is in relation to Inspire. It's been out since 2014, or FDA approved since 2014. And there's a few hundred papers or more looking at outcomes and predictors of success and complications and things like that. And then there's a number of not just startup companies, but more well-established companies that have designed products that also target that same nerve and similar physiology, and are coming to fruition and coming to market. In terms of outcomes, I mean, largely what we can talk about is the Inspire data. And the original paper was in 2014. It showed highly effective therapy. And I think the thing to consider with this is it's second line to CPAP. So you don't expect it to be as effective as CPAP, but in patients who have struggled with CPAP or aren't doing anything, if we can reduce the number on the sleep study to reduce the cardiovascular risk and provide improvement in their daytime sleepiness, those are really our two outcome measures that we're looking at. And some of the data shows that it can be upwards of 80% effective, meaning 80% of the optimal candidate may see 80% likelihood of reaching what we consider success. The more recent data that's come out is just looking at what are predictors of success. And Dr. Boone had mentioned the criteria. That's largely what the FDA says and what the insurance companies recognize. And that's been established for a decade now. As we assess patients that are coming in for this who have struggled with CPAP, we're also looking at the evidence that's shown certain anatomic features that predict the likelihood of response to this therapy and others. That's true of other interventions that we do as well.
I think what's really important to understand is that it's not for everybody.
Mhm.
And so the commercials sometimes paint that this is an equivalent therapy. It's not. If you were to compare CPAP and compare this device from an effectiveness standpoint, you would generally find that the CPAP is going to win day in and day out in terms of effectiveness. But in terms of comfort, acceptance, and tolerance, you generally will find that hypoglossal nerve stimulation tends to be better tolerated. And one of the things that's important to understand is that it's great to have CPAP, but if you only use CPAP a very small portion of the time, your benefit is limited. And so then if you're looking and comparing these two, if you have somebody who actually is effectively using Inspire hypoglossal nerve stimulation, it probably has as much benefit as long as they're using it consistently. And so that's really an important distinction. But it's really important to understand that they are different therapies. And the last important consideration is that what sometimes is painted is that it's a very simple thing and that it's a non-surgical alternative, but it is surgery. And while it's been generally very, very safe and been effective, as Dr. Huntley indicated, it is real surgery and there are actual risks. And so that's important for people to know.
One, I guess, data point to highlight is when you look at CPAP usage. So anyone who's tried CPAP knows that they're trying to hit that 70% mark, which means 70% of nights you're trying to hit 4 hours a night. When you look at compare usage of Inspire to usage of CPAP in populations, you are seeing more usage of the Inspire device than you are with CPAP. So, yeah, very much feeds into exactly what Dr. Boone said. It's although you may not see as much of a reduction, if the effective usage of it or effective control of the sleep apnea may be equal to CPAP simply because in a population, it's much better tolerated and it's actually utilized.
Okay. And I guess that segues into our next question here, talking about CPAP usage. This person is asking, when using the CPAP equipment, can you speak to proper maintenance and cleaning of the equipment?
Um, yeah, so it's kind of general maintenance, and there's recommendations that come from each individual company. But the CPAP setup essentially consists of the device itself, which has filter and a water reservoir, some tubing, and then a mask. I think the important thing is to replace stuff on a regular basis because, like anything else, it'll wear out. And the mask has usually a silicone interface that will either push up against the skin or the nostrils. And the more it's used, that will stiffen and kind of wear out. So replacing it regularly. The hosing is kind of soap and water that on a regular basis, just cleaning that out and making sure it dries well. And then the water reservoir in the CPAP machine too, making sure that's emptied and cleaned out and dried because mold can accumulate in there. If it's not taken care of, certainly you see people with sinus issues, not uncommonly, and simply because you're using a device that has either dust or mold spores or isn't as clean as it could be. There are aftermarket cleaning devices which people can buy and they put their CPAP supplies in it and it cleans it for them. They're effective. It's largely kind of knowing yourself and are you going to be the person who is regimented about replacing and cleaning their CPAP supplies on a regular basis, or do you need to stick it in a machine to and that's your routine? And either works. It's just what an individual patient is going to be able to do on a regular basis.
All right. Thank you. Okay, another CPAP question here. For some people, the mask and CPAP machine make them feel dried out, even though the humidifier is supposed to keep everything moist. Could you speak to that issue?
You want that, Mo,
Um,
or?
oh, well, so I'm not sure there's necessarily an answer for why you may be dried out, but one of the things certainly could be if you're mouth breathing.
Mhm.
In general, what I like to tell people is that mouth breathing is not how you're designed to breathe in sleep for sure, and in general, unless you're obviously sick or with a cold or something like it. You are supposed to breathe through your nose, and when you breathe through the mouth, number one of the major functions of the nose is to humidify and to warm the air. So when you mouth breathe, you actually will promote obviously dryness. So that may be one of the big reasons for it. We focus a lot of attention in what we do in clinical practice on actually helping people to breathe better through their nose. And in the years I've been doing this, which I don't really want to say for fear of giving away my age, I've really come to have a huge respect for what it means for people to be breathing really well through their nose. In addition to what Dr. Huntley mentioned before, which is that um, when you breathe through your mouth, you tend to have much more disrupted and fragmented sleep. Um, it also actually has significant impact just from things like CPAP tolerance and that kind of thing. So there's lots that can be done both medically and surgically to help people improve people's breathing through the nose. It's not generally going to be a cure for sleep apnea, so that's an important distinguishing point. But it can be really a very, very important adjunct to everything else we do to help actually with the overall treatment plan. So, short, that's a long answer to your question, but generally, if you're waking up with a dry mouth and a dry throat, it's because you're mouth breathing.
Very helpful. Thank you. Okay, next question here. Are there prescription drugs for which sleep disturbances are a potential side effect? Not sure if you can speak to that.
Um, Certainly. It's the first class that comes to mind is opioids. So someone who's on pain medication for chronic back pain or any kind of chronic pain, opioids are a risk for central sleep apnea. Um, that's the first that comes to mind. Um, in terms of sleep disruption, another common class of medications would be SSRI type medications. So something like uh not yeah, I guess Celexa or
Pro.
Lexapro, yeah, I guess was most common. Those actually suppress REM sleep. So it'll limit the amount of dream sleep or REM sleep that someone can get into. And then another class of medication that you see not uncommonly is benzodiazepines, and those can be used for a number of different um, issues from muscle spasms to anxiety, and that also impacts what we call sleep architecture, which is the stages of sleep. So dream sleep or REM sleep and non-REM sleep.
All right. Thank you. Okay, next question here. For people who would like a sleep study to determine if they have sleep apnea or other sleep disorders, what should they do?
First and foremost, they can talk to their primary care practitioner. And again, one of the things that's actually pretty easy to do for everybody is you can actually look online at something called a stop bang questionnaire. So that stop bang is a acronym for snoring, tired, observed pauses. P would be blood pressure. B is body mass index of greater than 35, age greater than 50. N is neck size. For men, that would be 17 inches. For women, that would be 16. And the G is gender. So unfortunately, for all the men on in the audience, you have one strike against you just by being a male. But in any event, if you check off all those boxes and you actually score positively for them, if you have 3 or more, you actually are at moderate risk, and if you have 4 more check boxes, it at least puts you at high risk. So it's a simple way to screen. It's not perfect by any means. And so if you are certainly suspicious of or concerned, the easiest thing to do is, of course, reach out to your primary to get a referral. You could certainly go to your general sleep physician in the community. You can also come to somebody like Dr. Huntley or myself who can actually certainly arrange for sleep testing. But the process would generally then follow with a sleep study. Usually, for most people, that's going to end up being a home sleep study.
Okay, thank you. All right, next question here. Any tongue or mouth exercises out there that could help with quality of sleep?
Not really is the short answer. So there's which is true and it's not true, I guess. There's a whole field called myofunctional therapy, which is trying to optimize muscle tone in the face and the throat. And there's certainly some data to suggest improvement in sleep quality. There's not great data to suggest improvement in really clinically significant sleep apnea. There's also an external stimulation device for the tongue that has been approved for snoring and mild sleep apnea. And most people have seen a TENS unit before that a physical therapist may use, which creates electrical stimulation to a muscle group and stimulates that muscle to try and strengthen it. Similar idea for the tongue, where this device is put on the tongue during the day or at nighttime prior to going to bed, and it's stimulating the tongue through some electrical stimulation to try and induce some muscle tone. And there's been some data to suggest it can be helpful for snoring and mild sleep apnea. Um, I guess the only other option is you could learn to play the didgeridoo, which is a Aboriginal instrument from Australia, and that's actually been shown to help strengthen the throat and improve sleep apnea, but it's not a very practical thing for most
Yeah.
people.
And part of the problem, unfortunately, with these things is that if you're going to engage in these things, it's not something you can do once and
Yeah.
expect that's going to be the end of it. So if you would have to do this, is something you're going to have to do just like you're going to have to do it every day. So, again, if I told you to, you're going to go to the gym and you're going to work your bicep today and you're going to look like, you're going to look like you're fit for the rest of your life from the one workout, you would laugh at me. And it's the same concept. You really have to obviously continually do that. And so while there is some limited data on it, the unfortunate thing is that it's not something that really is, unfortunately, practically going to be something people want to do lifelong.
All right, interesting. And interesting about that musical instrument.
Your
Okay.
neighbors will hate you, by the
Oh
way,
yeah.
That's true. That's a
uh,
good point.
uh,
Okay, next question here. Are there pillows or mattresses out there that are helpful with improving quality of sleep?
the so number one, obviously, pillows and mattresses can help just in terms of quality of sleep. Um, and that's very individual in terms of what people like in terms of a stiff mattress or a soft mattress. There's no right answer. But there are a couple things that are important. So it is important to actually think about your head position and your body position during sleep, especially when you have somebody who snores or who has obstructive sleep apnea. What in general you don't want to do for an airway that's obstructed related to sleep apnea, you don't want this. You don't want the chin on the chest. That's actually sort of an unhealthy position. The ideal position is actually to have the head somewhat in what we call a sniffing position, which means that the neck, which is the lower joint, is actually somewhat forward and the head's slightly backwards. That actually is an optimal position for airway. And there are pillows, usually they're cervical spine pillows that can actually help to sort of position you in that manner. And they help some people quite a bit. Yeah, the other thing is again, staying off your back can help. And the last thing is that mattresses and things that actually can elevate may help a little bit, but the actual impact is relatively modest for most people. Can have some limited benefit in terms of snoring and that kind of thing. But as a general statement, most of those things are just going to be individual, and their better benefit in terms of certainly obstructive sleep apnea is going to be relatively modest.
Okay. All right. Thank you.
Mhm.
Next question here. If falling asleep is not the issue, but waking during the night is the problem, then what would you recommend?
So I mean, the first thing I always try and get a sense is what's the expectation? So if the expectation is you go to bed at 10:30 and you don't move until 6 a.m., it's not really realistic just from a physiologic standpoint. The way sleep occurs is you transition from non-REM sleep or what's called N1, N2, N3 sleep into REM sleep, which is dream sleep, and that whole sequence takes somewhere between 90 and 120 minutes, and then it starts over again. So people will have three or four episodes of that every night. And it's not uncommon to wake up once or twice at the transition from REM sleep to non-REM sleep. It's Most people will get up and go to the bathroom, and sometimes it's tough to know, did they wake up because they have to go to the bathroom or did they wake up simply because of that transition? If they're having more frequent awakenings, well, that's not an unreasonable thing it's not unreasonable to screen them for sleep apnea, because if you're having frequent episodes of disrupted breathing, that certainly can contribute to arousals, which I think Dr. Boone mentioned earlier is just a change in brainwave pattern or a lightening of sleep, and that can lead to an awakening. The other thing to potentially screen for is sleep maintenance insomnia, which by definition is recurrent or frequent awakenings and then difficulty falling back to sleep. The last thing to think about is other disorders that could affect it. So someone with kidney or urologic issues where they're having to get up and go to the bathroom frequently, or if someone's on a water pill like Lasix for blood pressure and they're taking it at nighttime, it's going to make them have to pee and they're going to wake up frequently.
It's normal as we get older, we tend to have much more fragmented sleep. And so as we get older, we tend to actually wake up more. And one of the things that's also important to understand is that what really drives your sleep is actually what we call um, whether there's sleep homeostasis is how long you stay awake. You actually build up debt for sleep. And so
Mhm.
what's important to understand is that if you wake up at 1 o'clock in the morning after you've only slept for 2 hours, you haven't really repaid the sleep debt. And so it's generally easier to fall asleep. But if you wake up at 4 or 5 in the morning after you've slept for 6 hours, you've repaid most of that sleep debt, and your body actually is not really sort of ready to go back to sleep. Your brain's not. And so again, you'll have a much harder time at 4 o'clock or 6 o'clock in the morning falling back to sleep if you wake up than if it's in the middle of the night. That unfortunately is natural and normal. Now, there are things that we can do to help with that. But some of that is unfortunately sort of the normal process of aging and the normal process of sleep.
Okay, interesting. Yeah, interesting to think about sleep debt. So, yeah. All right, next question. Are there differences between seeing a pulmonologist and an otolaryngologist for sleep apnea?
Loaded question.
That's
Colin,
very
take it
loaded.
away.
Oh, thanks. I guess it depends on the subspecialty within each specialty. So, a general pulmonologist will largely manage obstructive sleep apnea with CPAP. Um, a pulmonologist who's done a sleep fellowship and specializes in sleep medicine and is boarded in sleep medicine will manage sleep disorder breathing, and they typically will manage it with CPAP, and maybe they'll talk about dental appliances and things like that, but they'll also manage other disorders as well. So we mentioned insomnia, we mentioned narcolepsy, REM behavior disorder. There's dozens of them. Uh, same thing can be said of an otolaryngologist. A general otolaryngologist will evaluate the nose and likely talk about some surgical options for obstructive sleep apnea in someone who's not done well with CPAP. Whereas a someone who's done further training and has board certification in both otolaryngology and sleep medicine is going to have more of a comprehensive view of things. So both Dr. Boone and I have board certifications and additional training in sleep medicine as well as otolaryngology. So we manage CPAP. We kind of look at the whole picture. So we'll manage nasal obstruction both medically and surgically as it relates to the complaint of nasal obstruction, but also how as it relates to CPAP tolerance and sleep disordered breathing. We'll manage CPAP and we'll treat patients medically for obstructive sleep apnea. And then we'll also assess patients for non-medical or surgical procedures for obstructive sleep apnea as well, and those who have not done well with CPAP therapy. And then lastly, we'll screen for those other sleep disorders that can be seen with sleep apnea can impact the daytime symptoms and nighttime symptoms for that matter, in addition to the obstructive sleep apnea and treat both. So we've tried to set up kind of a one-stop shop clinic to manage all of sleep disordered breathing from.
What I would say is that I think you're in very capable hands in a pulmonologist's office
Mhm.
and an otolaryngologist's office. But the key is this: if you are struggling and you are having a hard time with CPAP, you just have to realize that there are alternatives that
Mhm.
exist. And to some extent, you have to be your own advocate. You have to say, look, I'm really struggling with this. What else is out there? And our message to people is always this: there's always hope. There's always something we can offer. Some are more involved, some are less involved, but there's always something that can be done. And so I wouldn't say you're in bad hands in a pulmonologist's office
Mhm.
and you're better off
Mhm.
with an otolaryngologist. I would simply say that, if you're struggling with a certain therapy, you just have to think and realize that there's other things out there and just advocate for actually saying, I need somebody to actually find a solution besides this, whatever that may be.
Okay. All right. Thank you both. Okay, so we have a few more questions coming in, and then we will wrap up for the evening, as I know we're just over the top of the hour. But a good question here, when you go to a sleep lab to have a sleep study done, this person is wondering, how do you fall asleep?
Uh,
On your side. Uh, it's a great question. Now, it tends to be more daunting than it is in reality. I hate to say it that way, but most people are able to get to sleep and fall asleep. The other benefit of the sleep lab is someone is monitoring what stage of sleep you're at, and you get an accurate assessment of total sleep time, which you don't necessarily get as accurately through a home sleep apnea test. So even if someone thinks that they had a bad night of sleep or actually did have a bad night of sleep, as long as there's a few hours worth of data, you're able to get an assessment of what's happening during those few hours of data. A lot of times, many sleep doctors don't love the idea of patients taking sleep aids, at least one off to have a sleep study, simply because it can impact sleep architecture a little bit, meaning the stages of sleep.
Okay. All right, thank you. Okay, next question here. What are your recommendations for choosing an over-the-counter sleep medication?
don't. Melatonin, again, is actually a relatively safe thing. And so people can certainly use melatonin without too much concern. But again, I think you want to look into it a little bit and be making sure you're getting it from a reputable company, et cetera, just because it's not really very well regulated.
Yeah.
But in general, most of the over-the-counter sleep aids, unfortunately, are, again, Benadryl based. They're not great for long-term use. Again, they have side effects with Benadryl. Everybody's, I'm sure, familiar with the hangover. Um, I will also add to the comment that alcohol, as Dr. Huntley mentioned, is not a great sleep aid. Even though you might feel like you fall asleep quickly, it has such a profound impact on the sleep architecture that it actually makes your sleep worse. So, as a general statement, the unfortunate thing is that most of the over-the-counter remedies are ineffective. Now, there's also some stuff that's been advertised as, that I've seen on some of these news channels and things that suggest that there's the cure-all. The unfortunate thing, again, there's really little data on that. There's not much regulated to say that there's any real benefit. So just be cautious in sort of interpreting those TV claims, I would say.
Absolutely. Do your research. Okay. Last question here before I turn to the final question that I have for both of you before we wrap up the evening. What are the differences between CPAP and BiPAP?
So CPAP is one pressure. CPAP stands for continuous positive airway pressure. So it's one pressure. And BiPAP is bi-level or two pressures. So a higher pressure or similar pressure to CPAP during inhalation or when you breathe in, and a lower pressure when you're breathing out. In general, the goal of both of them is to gently blow pressurized air into the nose and the throat to keep the airway open or limit it from collapsing. So the analogy I always make is think about blowing into a balloon where the balloon pops open and now you can't flatten it out when there's air in there. Um, there's a difference in comfort for some people between both. So some people will have a hard time exhaling against CPAP because it's that constant stream of air that's coming in, whereas BiPAP can be a lot more comfortable. BiPAP's also used for, I guess, some other side effects that you can see with CPAP, like swallowing a bunch of air and being bloated and waking up with a stomach ache. You can see a little bit less of that with BiPAP for many patients. And then a lot of patient or some other sleep disorders within under the sleep disorder breathing category are maybe primarily treated with BiPAP as opposed to CPAP. So there's some different indications for the different modalities as well, depending on the specific type of sleep apnea and other comorbidities that might go along with it.
Okay. All right. Well, thank you. Any other comments, Dr. Boone, before we go to the last question here for tonight?
No comments.
Okay, perfect. All right. Well, for the final question this evening, I have one, which is what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? And Dr. Boone, I'll go ahead and start with you.
I may have alluded to this before, but first and foremost, just for those of you who suffer from obstructive sleep apnea and who are suffering with CPAP and really struggling, just realize there's hope. There's something else out there. We have a lot to offer. And again, I think it's obviously part of being, comprehensive and really assessing and evaluating and treating. But just realize that we have a lot to offer and there's a lot we can do. And I just want to make sure people have not lost hope and that they're stuck with this thing for the rest of their lives. So that's my message.
Absolutely. Great message. Okay. And Dr. Huntley?
He stole my answer. I think
Glad
the
to go
other thing
first.
I'll add is, but yeah, I 100% agree. Like there's more than just CPAP's a great option. There's more than that, and there's ways to optimize it. But also when we think about sleep apnea, evaluate the disorder. So is that the only thing going on? But then also define goals of treatment. And usually we define that in two categories. One is quality of life. So snoring, sleep quality, daytime sleepiness, morning headache, can't function at 2 o'clock in the afternoon because you need to take a nap. So those are very meaningful symptoms that we want to address. The other category is cardiovascular risk or the comorbidities that are associated with clinically significant sleep apnea and reducing that risk of stroke, reducing that risk of heart attack, reducing that risk of AFib or cardiac arrhythmia.
And I would always add to that, Colin, which I'm sure you alluded to, which is we want to make sure we treat the bed partner too. So
Yeah.
the snoring and everything else is really part of our goal is to make sure that when we treat quality of life for the patient, quality of life for the bed partner.
Absolutely. Great call out there. Okay, well, thank you both. Thank you so much, Dr. Boone and Dr. Huntley, for your time this evening. I know such great information was shared, and I learned a ton myself. And thank you all for attending and submitting your questions this evening. We will be posting an event survey, so you can let us know your thoughts, any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. Be sure to visit jeffersonhealth.org to make an appointment, stay up to date on upcoming events and webinars just like this one, and much more. Please also visit jeffersonhealth.org/livingwell for more health content, patient stories, research, and innovation. Be sure to also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to hearing loss, men's and women's health topics, and more. A recording of this event will also be sent to you so you can rewatch at your convenience. And if there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining us, and please be sure to stay safe and healthy. Have a wonderful evening. Thank you.